game-changing discussions on the big ideas that shape our thinking. This is One2One.
So let's go on and delve a bit deeper into this in that case. And I'd like to use institutional independence as an instrument for this, if you like. The independence of institutions, WHO, SGC, are often discussed but rarely understood. We've talked about the level of responsibility and power, if you like, that exists at the different levels. In many respects, it's actually more reassuring for an individual in your position than a country position, because as a nation, it'd be a country mandate, isn't there? But I'd like to ask, what does independence actually mean when a crisis becomes politically charged? In other words, does authority actually sit with you during the crisis, or with the science, or with the politics?
It's always a balance. The independence is necessary, but is also often almost end through trust, right? Your independence and the authority you derive from the statutes of your organization in a specific purpose is only validated if the people that you're leading or you're advising trust not only yourself, the institution, and very often the context. So every time I speak today on behalf of WHO, I need to be sure that the science is clear on the positions I'm taking. The ethics are clear as best as I can judge them. And, it's never easy to do so, but it's the only way, because, if you start swinging right or left or wherever the wind blows, then you're always vulnerable. And, I'm really privileged to work with a leader like Dr. Tedros leading WHO at the moment, that he's very clear on his principled stand on many of the important issues in the world. And our responsibility is to really take on follow his leadership, which is always clear, and having both scientific clarity and moral clarity are very important principles from which you then derive the authority of the independence that you then advocate for.
Absolutely. Scientific and moral ethical clarity, of course, builds trust.
Absolutely.
And you derive your authority through that. So all of these things are really important. But I'm going to ask you again, what do you think, in your experience, that independence is most often lost? Is it in the decision-making itself, in the communication, perhaps, or somewhere else?
Yeah, no, I think the independence, we all have to understand that the independence in of itself doesn't have much value. It really, what the independence, both where you get it from, is the authority that you derive from it in order to make decisions, and how those decisions have an impact on people that you lead. And that's very important, because people have to trust that the value of the independence is the trust that is gained out of it. And so I think that it's very important that we do have this independent thought leadership in organizations, because institutions like NCDC, like WHO, need to be in a position to look a political leader in the eye and tell him this course of action that you're proposing might be wrong, right? And if he doesn't have the scientific independence and authority and ethical clarity to do that, and then you may just tend to tell the leader what you think the leader wants to hear from you. And I'll give you a very good example. At the beginning of the pandemic, there were cases around the world evolving, especially in Europe, and we had a conversation at the very highest level. And I was in the middle of the room. Is your advice, Mr. DG NCDC, as I was called, to shut our airports? This is nothing to do. Of course, it had consequences on the spread of a pandemic. But you can imagine being asked for your advice on whether Nigeria should close down its airspace and close all its international airports.
And your response?
I looked at the circumstances at the time and advised in the affirmative. And in 2 days, our airspace was closed. So these are to derive the authority to advise the president of a country. You have to have both the scientific rigor and ethical clarity that you are not protecting anyone's interests. You're not working for any other interest other than to protect the country from the threat that you are supporting the country to protect itself from. So these are hugely consequential decisions where if you had a leader of a parastatal like NCDC where there wasn't trust, you're worried about his political affiliation or his whatever other affiliation, the president will not have the trust in you to trust the independence of your advice. So that's the point I'm trying to make, that it's not necessarily the independence itself, but what authority does it give you or what confidence does it give you to give the most consequential advice in certain circumstances?
Absolutely. So the independence of the science, if you like, is really protected by the authority derived through trust. And that's the only way really you can speak honestly about things in real time. You can always deploy resources quickly in a crisis when you need it. But I'd like to press in on the other side of that question. Where does that independence of science derived through trust, as you said, of course it's important, but what does it demand that you protect at times of crisis?
It's very important that both you're seen, that you consult widely yourself as a leader. Nobody expects, and you shouldn't expect it of yourself, to have all the knowledge that is necessary. It's always important to say, and even in our work in WHO, it's always clear, we invite all the experts in the world around specific topics to provide advice to the leadership on issues. So firstly, there has to be broad consultation with other experts in that field so that you derive the consensus position through scientific knowledge, acquisition, collation, but also consensus. And when you provide that, to make sure that you're providing it and stating clearly, this is the best information we have at the moment, that our understanding might change as science evolves. So it also requires a population and a group to be fairly understanding of how science works. And together, both from how it comes together and how you deliver it, and critically, how you communicate it. And one of the biggest challenges and opportunities that I had during this pandemic was the opportunity of speaking to 200 million Nigerians every single evening for a while, and that gave them, I hope, the confidence to understand that we've got your back on this, and hopefully led us to emerging from it not in a bad place.
Absolutely. So when the science becomes inconvenient, therefore, if you like, and the politics becomes quite loud, to what extent do you expect yourself, your staff, your leaders to be protected, shielded, insulated by the politics itself?
That's absolutely necessary, because there's a time your political leadership needs to come in and say, almost transfer their authority to you or protect you with their authority. And, I think, like I said earlier, that's what happened very well at the national level and what sometimes did not happen sufficiently in the state level in a few states. But it's very important that comes in and protects you and supports the work you're doing. If not, you're left alone, and that's not where anyone wants to be.
Yeah. So, Chikwe, I remember reading an article you wrote you published in Nigeria Health Watch, I think it was 2014, 2015. And I think it said, Nigeria needs its own Center for Disease Control. And hey presto, a few years later, you were doing the load-bearing work of leading the NCDC as its first director general. So, but then before 2016, we were responding to epidemics, were we not? But no institution really owned that responsibility. I think it's fair to say. So looking back now, I'd like your opinion on this. What was the real cost of that institutional absence? Not just in terms of outcomes, but in terms of coherence, authority, and speed.
Yeah, it's, Tokes, when I was just appointed, I was appointed in the summer of 2016. Later that year, and early 2017, many people would have forgotten this. There's a big meningitis outbreak in northwestern Nigeria, covering Sokoto, Kebbi, and Zamfara states. The institution barely wasn't existing, but we put some things together. I drove with the team up to Sokoto. We drove around Kebbi, Zamfara. If you've seen a case of meningitis, you will never forget. It's a terrible disease, right? But I saw patients being managed with infusions hanging on trees outside the premises of hospitals and clinics because the wards were full. At the time, there was no national reference lab. There wasn't any lab to actually test and confirm, and to get a sample from a case of meningitis is a pretty tricky thing. You have to take a cerebrospinal fluid. Mm-hmm. So very difficult disease to treat, to manage, to diagnose. We then did an analysis of that particular situation and analyzed the number of deaths that we could have prevented if we had the capacity to act a little bit earlier than we did. We were very open with this. And I say to the team, we are responsible for these number of deaths. We may not be able to prevent every outbreak because you have to find them. But once you know that there's an outbreak, you must be able to prevent its spread and reduce the number of cases. So how does this link back to your question? I think in our country, we had normalized the fact that people die from meningitis, that people die from measles, that people die from cholera. I mean, these are diseases no one else is dying from. Why should Nigerians be dying from cholera? That can be absolutely prevented. You cannot get cholera if you drink clean water. Yeah, it's impossible. So there are diseases that no one else around the world is dying from. That have basically, if you work in the UK, you would never see a case of cholera throughout your career. So the lack of an institution with the knowledge, the expertise to drive this expertise, to drive the country forward in this area has cost us millions of lives. And that's why now we have one. I hope it continues to grow. I hope it continues to find its mandate, find its space, and grow its service to our country. The work we started in 2016 cannot stop. We have to keep growing this institution. The US CDC has over 50,000 people working for it. Nigeria CDC has less than 500 today. So if we want an institution to fulfill its mandate for the Nigerian people, we have to invest in this space and keep investing. If not, we'll keep losing our best. And that's not how any country grows.
Absolutely. And prior to that time, prior to 2016, of course, surveillance existed, professionals existed, even some level of coordination after a fashion. Yet, of course, it was clear that something fundamental was missing. We've defined and described that something fundamental that was missing. So, but my question is, how do you, as a systems leader and builder, recognize that moment where activity is present, but of course, that institutional ownership is missing?
So, Tokes, when I got to NCDC, yeah, you're right, surveillance did happen. So every local government would collect data on infectious diseases, store them on an Excel sheet, send that Excel sheet to the state level. Someone at the state level will collate 20 Excel sheets, for example, from 20 local governments, try and put it together into one. And then the states will try and collate that, so it was a completely dysfunctional system, right? We started the digital surveillance system with a very simple platform called SORMAS, introduced this sequentially into all the states, all the local governments. So once you enter that data at the LGA, we can see it immediately on dashboards that we put up as a national. This is not cutting edge science. These are basics, right? So by transforming a system and making it easier for everyone to do the work they were doing, and then for people to see the results of the reason we could tell Nigerians at the pandemic every day, if you remember, every evening at 9 p.m., we would announce the number of new cases, the number of deaths. The reason we could do that was a system we had put in place 2 years prior the beginning of the pandemic. So this is how we can grow as a country. This is just one example, to put in the systems, to build those systems, to trust them, to enable their growth. And then slowly, we save ourselves from tragedies that can happen. So I think it's very important that we keep pushing on these small opportunities to develop the work that we do. But, there are no short-term solutions. You have to think long-term, solve one problem, and that problem takes you way into the future.
So if we apply that lens more broadly to the broad cameras of Nigeria's healthcare system, we've talked about the fact that, of course, activity can exist in the absence of, structured of progress and structured institutionalized progress, and for that matter. Do you see other parts of the healthcare system across this country in which, of course, activity exists, but there isn't that institutional ownership and harmony? Do you see it elsewhere outside of public?
Let me flip your question slightly and actually demonstrate one area where I see a lot of progress. For years, our health financing has been in a mess. We've never been sure, are we running a tax-funded system, an insurance-funded system, a fee-for-service-funded system? Because we're doing all of them in various ways, shapes, and form. For many years, you ask people, how many insured Nigerians do we have? No one can give you an answer. But now I see for the first time some serious thinking happening in National Health Insurance Agency in this country. I can see progress happening, digitalization, HMOs being pushed further than ever before. And I'm confident that if the institution is allowed to grow and continue, that we can have a similar transformation in the health insurance and health financing landscape. But none of this can be done overnight. So each of these transformations of specific areas require time, energy, and consistency. And I worry sometimes that our 4-year political cycles is really an impediment for progress in the health sector, because the health sector is not, progress is never rapid. You need time. No matter how good the idea is and the transformation is, you need time. You need policy consistency, leadership consistency. And if there's a change in the political landscape after 4 years and a whole new set of leaders come in, the risk is that no matter how good ideas are, they never just have the time to go.
But Chikwe, is the 4-year political cycle the problem, or the lack of a coordinated handover and buy-in from one administration to the next?
I mean, they're all linked. I don't have any magic insights into what the problems are, but they're all components of this. And very, very often, you see great initiatives that die not because they're not perceived to be valuable, but because, the next leader doesn't want to be associated with something that the previous leader started, unfortunately. So,
I think, of course, we agree that we're not ought not to be the case.
Absolutely.
And should it? So many countries, Nigeria included, use the terms primary care and primary healthcare interchangeably. From a systems point of view, could you tell me what you think is lost when a clinical care system like primary care is more or less subsumed within a public health program? You know what I'm leading up to.
Yeah, I think, it's a complex question and with complex set of circumstances, but
To make it clear, Russ.
yeah, well, I do. So let me give a simple example, going back to our health financing anecdote, so we can continue from that example, right? When you start a health insurance model, but you continue funding your public health care delivery through taxation or through money, then there's no incentive for people to move from one to the other. So for health insurance really to work, money has to follow the patient, right? And so you take money out of tax funded systems into insurance funded models, and that way there's an incentive for people to pay and to derive benefit. And then the system grows. You have to see this as a system that is interconnected at all the levels. So I do think, the radical reform that have happened in other sectors, I go back to what I said in the beginning. We are, the Ministry of Health, if you go to the ministry today, it still has the same departments that it had 40 years ago, right? So we are not courageous. There are many impediments to actually transforming the sector. So the question you're asking, I don't think, why I've gone off a little bit on a tangent is, I don't think the problem is that we don't understand what needs to be done. I just don't think that the political imperatives have allowed us to do what we need to do. And whether it comes to paying doctor salaries and strikes and infrastructure or hospitals, there are really fundamental questions. And I hope we can get to a space where we can answer them.
Yeah. So I'm going to ask you to name it because you're eminently qualified to do so, Chikwe. So in your experience, what usually needs to happen, therefore, politically, intellectually, institutionally, before a country is ready to move from funding activity to building that missing institutional spine? That's what we're talking about, after all.
Yeah, I think right now we have probably the most aspirational Minister of Health that we've had for a long time. And I've seen real fundamental changes happening in the sector at the policy level, addressing very important areas around the value chain, for instance, in health products, manufacturing, distribution, access. But there's a bigger issue in terms of, what is the consensus on what a state government should be doing, what the federal government should be doing in terms of healthcare. I was surprised when I came back to Nigeria and I asked a colleague, my peer, who was a consultant in a teaching hospital at the time, I don't know if it's changed, as a consultant, what is your commitment to the care you're providing? Do you have a consultant's contract that articulates, as a consultant, these are the number of rounds, the number of clinics, the hours? No, I don't know if it's changed. So if you don't know, if what you're expected to do is not articulated in any position, how can you be held accountable for what you're doing? Right. I went back to the teaching hospital where I trained in Enugu at the time, a few years ago, so the numbers might be different. There were 23 consultants in obstetrics and gynecology in a single teaching hospital. I asked them, how many deliveries happen? How many patients do you see? There was a big disconnect between. So it's very easy to say doctors are on strike, doctors are not paid well, but we have to really look at the fundamentals. And so why I'm avoiding answering your question, I think that too many of us that jump to the answers without going to say, listen, a teaching hospital serves this purpose. These are the human resources it needs. These are the other resources it needs. This is how we'll measure it. And based on this, we will fund you with X. And until we do that, how many primary health centers are there in Nigeria? Who is receiving what resources? What patients are there? If we don't know this, we cannot manage. So we cannot manage stuff that we cannot measure. And so I'd rather avoid answering the questions of how we can fix, to start with the question of how we can understand. And once we can understand, we can start a process of fixing. But that's, I think, the starting point of where we need to land in our sector.
Absolutely. And in many ways, you've answered the question, because we're talking about building like missing institutional spine. The first thing is we have to be comfortable, I suppose, operating in a certain vagueness, not preempting the answers to questions, but as you said, aligning what the purpose should be with the necessary steps that need to follow. So I'd like, we've talked a lot already about COVID and pandemic preparedness and epidemics, but we've also talked very briefly earlier, and you dipped into this from time to time. Some of the other examples and experiences you've had. So talk to me about meningitis, Ebola, monkeypox.
So let me actually start with Lassa fever, because Lassa fever is a disease that is unique to West Africa. The ecology of West Africa enables its transmission. We had and have a big challenge in Nigeria. So when I came in, there was some expertise, especially in the Irua in Edo State, Irua Specialist Teaching Hospital, but we were not investing anything in the science, in understanding the disease, in the diagnostics. So I saw this as a challenge, but also as an opportunity for us to lead. So the initial thought process was to expand the expertise from Irua. First, we started to 2 other centers that had a significant amount of cases in Owo in Ondo State and Abakaliki in Ebonyi State. And we supported from NCDC colleagues from these 2 other centers to go to Irua to spend a month to learn, to develop expertise, and come back and develop their centers. It was these 3 centers that ultimately were the foundation of everything we did in COVID, because that was where the infectious disease expertise was built around Lassa. So the work we do is at the intersection between science, public health, and the third area, I call it solving Nigeria's day-to-day challenges. Because if you pick a scientist from one place to somewhere else, and you teach him about managing cases with Lassa, and there's no running water in his ward, the basics are not there. So very often, NCDC was actually providing centers, building treatment centers for teaching hospitals. No teaching hospital in Abuja, the first infectious disease teaching hospital in the federal teaching hospital in Gwagwalada, was built by NCDC and located in the hospital. So we found that our responsibilities were not just around supporting disease-specific expertise, but was in building the infrastructure around it. But the broader point is, once you start building, people start developing knowledge, our confidence grows, our expertise grows, both scientifically and clinically, and that then saves lives and also builds our own scientific competence. So the disease might be slightly different, but the thinking process on how to prevent, how to manage, how to treat, infection prevention and control, are very often similar between them. So what you learn from one, you take to another, and collectively as a country, we grow our expertise.
Absolutely. So Chikwe, you obviously have spent a significant part of your career focused on the public sector and public health. You sit now in a very strategic vantage position at the World Health Organization. But of course, we are sitting in a country which is perhaps, reflective of what is happening across much of sub-Saharan Africa as well, in which we are largely dependent on progress being reverse engineered from the private sector into the public sector. But there has to be an optimum balance. What is your vision for how the public sector and the private sector ought to work together?
So I firstly, to think that we are an incredibly blessed country, and blessed in many different ways, right? Firstly, is a little bit of just coincidence that, everyone in my generation, our generation, that was kind of fairly competent in the sciences to a certain level was pushed into medicine.
Yes.
Right? Whether we liked it or not. So we already have a selection of very good people, even if I say that, academically gifted individuals in this field, right? And secondly, a few of us have had opportunities to train, to become specialists, and we also grew up in an incredibly hopeful time in Nigeria, in the 70s and 80s, early 90s, where many of us, were formative years. We're really hopeful. And that had a lasting imprint in many of us, myself as well. So what we haven't done sufficiently is translate this emotional desire and competence to do better for our country into reality, because the systems constrain us. So I think as we begin to unravel and open up these opportunities, there are many. We have many of our colleagues, our peers. Yes, I'm in public health, but we're all part of wider medical communities. I've seen many colleagues come in, set up practices, figure out how to swim in this very difficult area, right? And do incredibly inspiring work, set up hospitals, services, not just in Lagos, but across the country. Despite the challenges, we have to remove the despite and actually see this as an opportunity and not a constraint or a competition for the public sector, and see how can the public sector use the private sector or benefit from the private sector and vice versa. And I think that's where magic might happen if we get it right, because, we have probably the biggest pool of skilled health sector professionals, not just doctors, around the world. And we have to be intentional on how to bridge that gap. Again, I don't want to provide all the solutions, but I think that there's an untapped opportunity in that space.
Of course. And of course, one of the essential roles that must be warehoused in the public sector is that it sits as a body, if you like, to commission and to regulate.
Absolutely.
Standards and to commission services. Absolutely. Can I tempt you to comment on that and perhaps append to that anything else you feel should be happening in the public sector and that it's intersectional with the private sector?
Yeah, you see, I think that for us in this space, there's actually nothing new to be done, because a lot of these things have been solved in many other contexts. We just need to understand, how do we adapt, not bring everything, no copy and paste solution, but adapt them to our context, And when I did a small project in one of the states in southeastern Nigeria, and I went to the state Ministry of Health at the time, and I asked them for a registry of the hospitals in that state. I was given a notebook, handwritten notebook with names and vague addresses. How do we manage registered sector in state X if we don't even know who is practicing here, what's your bed capacity, what services do you provide? So either the public sector has to have the competence, expertise to be able to manage the sectors. Managing it means first understanding what you have, where the gaps are, what and all of that. So, yeah, I don't want to sound too negative. What I say is, in that gap are the opportunities, incredible opportunities to open up and to serve our country, and not to compete across sectors, but really to benefit from the resources that we all bring.
Certainly. So, Chikwe, with everything that you have seen, both institutionally as well as personally, what kind of leadership do you feel that the world, that Africa, that Nigeria needs in advance of the next global crisis?
Wow. The leadership is such a broad term, but in certain areas, I don't think we can get away from finding the expertise that we need to run whatever we want to run. If we don't think that a teacher can fly an airplane, if we don't think that a doctor can run a telecoms organization, why do we think that we have to consider all sorts of factors in looking for who will run our big teaching hospitals, who maybe have never had any managerial experience? Where will they get it from when they're given an institution like that to run? So I do think we have to be intentional. I know that in our country we have to solve for geographical diversity, we have to solve for religious diversity, we have to solve for all sorts of issues. Granted, within our 200 million people, we should be able to do that. But to get our country to work in specific cases, we need the expertise, the people that understand what they're asked to do, have proven that expertise, and are committed to working and delivering on that issue.
So what next for Chikwe Ihekweazu like this?
Well, Stokes, I'm really in a privileged position at the moment. I'm very lucky to work with a team at the World Health Organization where every day, leading the emergencies program, I'm constantly at the alert in terms of where the next challenge is coming from. On the infectious disease front, I'm fairly confident that we have progressed a lot. What really hurts me at the moment in terms of our work is the countries where there's a big public health crisis, consequence of a political crisis. So countries that are unstable for whatever reason, where the big health consequences that we have to deal with, because a little bit we're at the bottom of the pyramid and we can't really influence the politics. So I'm lucky to be there. I'm lucky and happy and proud to be working with a leader that I trust and I'm committed to. And we'll see what the future holds.
Absolutely. Absolutely. I won't press you any further.
Thank you.
But I will speak of the future. So finally, Chikwe, after everything you've experienced, the crises, the politics, the pressure, what precisely gives you hope about the world we live in today?
Yeah, Tokes, what gives me hope? Literally, two things. First, my experience at NCDC is we are a gifted country. If I had taken on face value what I had seen in the first month of my time at NCDC, I would have run away. But we are a resilient people. It is the same people that grew, that developed themselves, that developed the expertise, that went way over the call of duty. The first 3 months of the pandemic, nobody was working in Nigeria. Everybody was home. We had 20 teams from NCDC in 20 states in Nigeria supporting them. There was no foreign support. There are no partners. This is the core team. So I have seen our country work. It's an incredible experience seeing it work. So that leaves me with a lot of hope about the future. I think being at the World Health Organization at the moment is also quite an eye-opening experience because of the multilateral nature of the work that we do. And the fact that doing the World Health Assembly, where every country is on the table, and whether you're Seychelles with 200,000 people, or whether you're China with 1.4 billion people, you sit around the same table, you have conversations, you have 2 minutes each to speak, and you have to reach consensus. And I have witnessed the power of that process and why it is so important that as long as we have nation states in the world, we have to go through that consensus building process in a space like public health. So my life is already a blessing, and to have played a small role in these processes, I think I can go to bed and sleep well at night. But my job is not done.
Dr. Chikwe Ihekweazu, thank you for your service. Thank you for joining us on One2One.
Thank you very much, Dukes.
Thank you, Chikwe.
Thank you.
Pleasure. Thank you.